Hi, everybody. This is Alexa Tinsley, Director of Community Engagement here at Jett Foundation. Thank you all for joining us here today for our webinar on respiratory management in Duchenne with Dr. Schell from Nationwide Children's Hospital. We're going to give people about another minute or so to hop on. We have quite a few logging on with us today. But while we're waiting, if you could put where you're from and your or your child's age into the chat, that will be wonderful. So we can get some interaction there and see where you guys are from. And we will be right back. Thank you, guys. India, awesome. Cincinnati. Right in your backyard, Dr. Schell.
Absolutely.
Illinois. Okay. All right, perfect. We will go ahead and get started. Again, I am Alexa. I'm the Director of Community Engagement here at Jett Foundation. Thank you all for being here from around the country and around the world. So thank you all for making the time to be here. To learn more about our topic of respiratory management in Duchenne with Dr. Richard Schell from Nationwide Children's Hospital. We are so grateful to him for helping us make this webinar possible, sharing his knowledge and experience and expertise with us. Dr. Schell is a professor of pediatrics and section chief of the Department of Pulmonary Medicine at Nationwide Children's Hospital and the Ohio State University College of Medicine. He also plays an active clinical and research role in the care of patients with neuromuscular diseases in the neuromuscular clinic at Nationwide. Before we get started, I just want to mention a few things. We do hold these throughout the year, so we'll have another one we have our World Duchenne Awareness Day coming up in September, which will take the place of our webinar in September. We will have one coming up in October, so stay tuned for that. And then we have Driving with Duchenne in November planned as well. So just so you know, those are coming up, so take a look at those. This webinar is also being recorded, so if you do have to log off for any reason, it will be up for you to watch later on our YouTube channel, and we'll also put it on our social media and email it out to all of you and also anyone else who is not able to be here today. Presentation today should take about 30 minutes, and after we'll have a Q&A. So there's a Q&A panel at the bottom. On mine, it's the bottom right, so I hope it's the same for you, the bottom right portion of your screen. So we will be using that for the Q&A section after the presentation. We will be monitoring the chat, so if for some reason you forget and you put it in the chat, we'll make sure that that question gets answered. And with that said, I will hand it off to Dr. Schell. So thank you.
Hi, everyone, and I'm thrilled to be able to kind of discuss, something that I do on a daily basis. And I've tried to make it more, like I said in my title, the art of respiratory care in muscular dystrophy or Duchenne, because there's a lot of research out there. There's a lot of things that we do, but there's also a lot of art to doing this, and every patient is a little bit different. And I'm sure that we will have some questions that may pertain to one patient, and maybe it won't pertain to others, but I tried to do this lecture, and I usually try to do this lecture not only with families in mind, but medical students, residents, fellows, what my brain thinks when I walk in the room in our muscular dystrophy clinic. And really the first thing, of course, there's a caveat to this that, we've been using Zoom for now 3 years now. And if we do something wrong, there we go. There's something you learn every time that you use Zoom. So this is what our clinic looks like. This is, we have a multidisciplinary clinic at our center at Nationwide, and our patients know to spend to bring snacks, bring toys for their kids, or things to talk about, because we have a lot of people that we see, and we have a lot of people in the clinic that need to see them. So in our clinic, pulmonary is certainly part of that. But the neuromuscular docs are there, and we have a cardiologist, and we have a gastrointestinal doc there. Not all the time, but most of the time. And we're working on having a PM&R specialist there as well. But we have physical therapy, we have social worker, we have dietitians, our genetic specialists are there as well, and occupational therapy. But I think most important of all those two are our nursing staff that puts all of that together and helps run our clinic as smoothly as possible. So there's lots of pieces and parts, and I think that's really what's really nice about a multidisciplinary team, and how it helps my mind think, is that I have all these other people that I can ask questions to. If I go into a room and you tell me something that I think is more appropriate to ask the occupational therapist, I have the occupational therapist right there to ask that question and make sure that they know that that's top of your mind. So I think it's always important when you're at any of your clinics to make sure in that beginning, especially when the nurse is in there, let them know what you're most concerned about, what your biggest things that you want to talk about, because it may not be respiratory all the time, but and that nurse can then kind of align who's coming in to see you to help with that. So I throw this out here. I mean, these are classic pictures, of muscles, but I always want people to understand, like, when we see patients with neuromuscular disease, and the physical therapist and occupational therapists work with you, and I'll use this a little bit later, but it's we think about big muscle groups. Everybody asks, like, when patients lose their ability to walk and have to get wheelchairs, and we think about the big leg muscles and arm strength and things like that, and shoulder strength, and what we can do with that. I always remind people that there's hundreds of muscles that affect your breathing, and those muscles also get weak. And the thing that I try to stress with that is that patients with Duchenne muscular dystrophy they are not born with lung disease. And for the most part, healthy patients with Duchenne and Becker also do not get lung disease. The patients who get pneumonia and infections and have recurrent problems, or have trouble swallowing, or things that affect the lungs, yes, they can have lung disease later on due to some of the changes or inflammation that's happened. But for the most part, the lungs work just fine. It's the muscles that surround those lungs that help you take that big deep breath, help you exhale, help you cough. Those are the muscles that are affected. And a lot of the devices that we use from a respiratory standpoint, the cough assist, BiPAP, are really just, they're a wheelchair for those lung muscles. And I think it's a way that I've really focused on working, especially with the younger population, to get them to understand, like, this is something that your lung muscles need, just like your leg muscles do. So when I walk into a room and look at a patient, there's a lot of times that we can just look at someone and know kind of what stage they're in. But from a respiratory standpoint, initially up to about age 10, 12, 14, there's normal breathing, lung function improves overall as people get bigger, because lung function is a measure of how tall you are. And that's why it's really important to get a good height in clinics. And we try to standardize that. We use an ulnar length. So our nurses or respiratory therapists will measure the length between the length of your ulnar bone from your wrist to your elbow. And that's a measure of it's kind of a measure of height for someone who might not stand still to stand up tall, or is in a wheelchair. And that next stage, there's normal breathing, but sometimes we start seeing a weaker cough. And those are, we'll ask those questions in clinic. Do you get infections in between visits? Are you having any breathing problems? Do you feel like you're breathing harder? And in the early teens, this is also a place where those young men and patients can actually talk to us and tell us what they're feeling, how they're feeling, what kind of things are going on from a breathing standpoint. And I think it's really important to try to let them do some of the talking in clinic as well, because it's in these early teen ages that we start learning how to take our own care of our health. I mean, obviously these young men are going to need help along the way, but starting early to get them involved and making them understand, like, this clinic is a safe place to talk about any problems that they may have. That next phase, there may be some normal breathing during the daytime, but maybe they start having some problems breathing at night. We call this hypoventilation, hypo being low and ventilation being breathing. So, shallow breathing at night. When we go to sleep, all of us lose some muscle tone, but our brains keep our lung muscles, contracting and breathing for us. But when those muscles are a little bit weaker, then the brain tells them to breathe, but they may not take as big of a breath. So, this is where we start talking about, asking some questions about, how are you sleeping at night? Do you wake up a lot? This is where we might start thinking about doing sleep studies to pick up things early. And I get it, and we'll talk about sleep studies a little bit later with a slide too, but sleep studies are not fun. They're not always convenient to do. They may not necessarily be associated with the center that you're at, so it makes it a little bit harder, but they are really important tests and they tell us a lot of information. The nice thing is that they are working on some home forms of sleep studies that people can wear sleeping in their own bed. The big thing to remember with this is that to diagnose hypoventilation, we have to be able to measure the carbon dioxide, the bad gas. And that bad gas is something that's not always measured in every sleep study unless we really ask for it. So it's important that if you're scheduling a sleep study that you can certainly ask, are you going to be measuring my child's carbon dioxide level? Because that is what we're looking at in muscular dystrophy. Now, early on, when patients, whether or not they're on steroids and gaining a lot of weight, or they just have big tonsils and maybe snoring, there's definitely an increased incidence of some obstructive sleep apnea early on. And sometimes, before anybody needs any support from their breathing, they do, we use our ENT colleagues and, we may remove tonsils or look at that a little bit closer. And then that fourth stage is where you have trouble breathing when you're awake and asleep. And that, is more into the adult phase of this process. And, we have devices to kind of help people clear their secretions and stay healthier and just, have a better quality of life from a breathing standpoint and then from an overall health standpoint. So in clinic, at least in our clinic and any other clinics that you're out there, there are different organizations that certify centers, but for the most part, we like to do pulmonary function testing at least once a year. I would say in our clinic, we see our patients about every 6 months as best we can. So we do get pulmonary function tests at each visit if we can. And this is just an example of what it looks like if you've never seen one. But, it is, we wear a nose clip to prevent air from getting out of the nose, and it's just breathing normally. And then our respiratory therapists, I sometimes look at them as cheerleaders because they're the loudest people in our clinic, because they're gonna, start getting really excited and telling kids to suck, 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 and blow really hard. And, you hear them saying blow, 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 blow all the time. So I know that they're getting our pulmonary function tests, and our RTs are very focused on pediatrics. There are some games that some of the PFT devices can play to help kids blow out, fire from a dragon's mouth, or things like that. But we look at a bunch of numbers, and hopefully when you're in clinic with the pulmonologist, they kind of go over those. But the big one that we follow is the forced vital capacity. So that's how much air the capacity they have in there. But we also look at measures of muscle function, and those are muscles that you use to take a breath in. They're also muscles that you use to take a breath out. And we also look at the cough flow. So we have some of these patients, if they're able to cough into this device, and measure how much air is coming out per liter in liters per minute. And that helps us to give a better estimate to how strong those muscles are. And we, though we're working on therapies, gene therapies and other, medical therapies for Duchenne and Becker, we still don't have a really great way to stop the pulmonary function tests from declining over the years. It is known that this will happen. Medications like prednisone, deflazacort have been shown to slow that progression, and some of the newer IV medications that are out there that people are getting have also shown to slow that. But we haven't really come up with anything that stops the progression of the losing some of that muscle strength in your lungs. So I always tell parents when I see a patient in clinic, like if their PFTs are down but they have no clinical symptoms, like this is just a number we work with. Like it's a number we follow. It's a number that kind of gives us a sense of some risks, especially if someone needs to have surgery like scoliosis surgery or other surgeries that might come up. But clinically, I feel like it's more important to take that into account too, and not base everything that we do on just a number that a pulmonary function test might give you. Because of that pulmonary function test, we may talk about doing a cough assist. And when you get to a point where that cough peak flow is at a certain point, and the numbers we usually use are about 260, whereas a normal cough is probably 400 or above, 400 to 600. But when it gets to 260, we might talk to you about, like, I think it's time to get a device that helps someone cough. And all it is, it's a cough assist. And I look at it as like a Hoover vacuum cleaner. Like it gives you a big deep breath and it sucks it back out again. And it takes some time to coordinate, but it is a great device, and people either love it or hate it. But even if they hate it, they understand mostly if they use it that it's really helpful. It's helpful. In my head, I look at it as physical therapy for all these lung muscles. You're stretching them, for kids and adults who are in wheelchairs and they're kind of scrunched down all the time. It makes you take a big deep breath, and it opens up all those little parts of your lungs that may not always get air in them. And it helps clear the secretions, because like I said, the lungs are usually normal, but normal lungs make mucus. And if you still can't cough it out, that mucus can be trapped in there, that mucus can get infected. And that's where we start seeing problems with pneumonias and other things, especially if someone gets a virus. So when I prescribe a cough assist, I usually ask patients to do it once or twice a day on a regular basis to make sure that their bodies are used to using it, that people understand which buttons to push, so that in an acute situation or when someone starting to get sick, you can grab it and it's just a commonplace thing that people do. Without the device, there are some people that do a manually assisted cough too, like you use a bag valve, a mask, and give somebody a really big deep breath and then have them cough out. Because really what this is doing with both ways of doing it, it's getting the diaphragm, which is our strongest muscle usually from a cough standpoint, into the right position when you take a big deep breath to cough. Because if you think about it right now, and usually when I say this, people start coughing, but to be able to cough and clear secretions, your brain automatically tells you to take a big deep breath. So all the cough assist is doing is helping a patient with Duchenne get those muscles that big deep breath that they may not be able to do on your own. And it just takes time to get used to coordinating. As it sucks it back out, that's the best time to try to coordinate a cough. But I know I threw some numbers out there, but I also would say that if your child, or if there are any people with Duchenne on this right now, if you're having difficulty bringing up secretions, or you feel like there's always stuff stuck down there, or you may have trouble eating and things go down the wrong way, even if your numbers are not at that 260 point, if clinically you need it, I would ask your team to see if they can get one, because I think it's a great device for anybody to have at home. So this is my first slide attempt at PowerPoint that has animation, so I always like to put it in my slides, but it also hits home that, in my opinion, chest therapy, cough assist, clearing those secretions is the most preventative therapy you can do when your muscles are weak. and can't clear the secretion. So again, you'll hear this again, but I look at it as a wheelchair. So we turn it into a wheelchair and it just moves along. So I think it's really important to keep that in mind, that the best preventative therapy are ways to clear secretions, especially when we get to a point where that cough may be weak enough that we need to. I throw this in here because there are a lot of people out there, including some of my own colleagues, that love to use the vest. The vest looks it's a vest, and this is a picture of the most common form of it. It was a device used for cystic fibrosis to help them mobilize their own secretions. CF patients have abnormal lungs. They have really thick secretions. They get infected all the time. And this vest works great because it uses some shear forces and it vibrates pretty dramatically, and CF patients can cough really hard, so they can get that out once we can shake it loose. In Duchenne muscular dystrophy and other muscular diseases, we haven't shown great evidence that it works well. It probably works really well in a hospital situation if you're in the hospital and you have a pneumonia, or it may be good for patients who get recurrent pneumonia to help shake that secretions loose. But it costs a lot of money, and it takes a good 20 to 30 minutes to do every day. And when I have a patient who has a vest, if you have neuromuscular disease, the more important therapy is the cough assist. If you have a vest at home, it's very, very important to do a cough assist after you do the vest. Because in my head, there's no use of just shaking the mucus loose if you can't get it out. So the combination of the two may work really well together, but if I have to pick one for a patient to do all the time, it would be the cough assist. I mentioned scoliosis. So a lot of kids and adults with any neuromuscular disease will get scoliosis because the muscles that go up and down the sides of the spine may not be as strong, and sometimes that spine will curve. I think that it's important to keep track of this. I think good clinics will always be monitoring that. We have a good relationship with our orthopedic surgeons here, and once we see scoliosis kind of starting, we will get those people involved. But there's really good evidence that if we correct the problem with surgery, the patients do better overall. And when you combine doing spinal surgery with really good proactive respiratory care, like using a BiPAP machine, the quality of life goes up even further, and the length, that we have with patients goes much further. I think it's important to point out that, pulmonary function testing may not actually improve after spinal surgery, but I can tell you that respiratory symptoms in my head do seem to improve some. But we're certainly looking at that, and there's lots of people who do all types of different scoliosis surgeries. So, if scoliosis is advancing, the important thing with Duchenne muscular dystrophy is to plan this surgery at a time where we feel they'll get their best benefit from it, and at a time where their lung function is not so severe that it causes more risk to go to surgery. Though we've certainly done surgery on patients with really low lung function, and people have done really well, as long as the center that you're at has a good protocol to follow for patients who have neuromuscular disease post-operatively. And at our center here, when you're going to surgery, we always talk about using BiPAP as people are waking up from the operating room. And that's a whole other lecture that we can talk about. And I have a few slides in emergency care coming up in a second. So we talked about sleep studies as well. This is just kind of a picture of what happens in a sleep study. The thing that is not on this picture is how bad the glue smells. So if anybody on here has had a sleep study, they know what I'm talking about. And I don't understand in our day and age with our medical capacities that we have that we can't come up with some other type of glue that doesn't smell so bad. But we do glue some with dissolvable glue, I should say. We do glue some electrodes on patients' heads, and that allows us to evaluate what stage of sleep people are in. Because when we're looking at hypoventilation, we really want to know what we call what's happening in REM sleep, or what's rapid eye movement sleep. People also call it dream sleep. So if you've ever watched somebody who's sleeping and their eyes are going back and forth, that's definitely the time that you may be dreaming for sure. But we also want to know how deep people get to sleep and what stage of sleep that they may have more problems on. Patients with muscle diseases will have more problems in that dream sleep. So we like to get a good sleep study so that we can get enough time during that sleep study in REM sleep so that, we can make a determination. And a lot of times insurance will require us to get a sleep study at baseline. And then if we feel like patients need support, which is BiPAP, then we will repeat a sleep study on BiPAP. But some of them are getting a little bit more lenient, and we're able to base the need for BiPAP on other clinical symptoms and maybe even pulmonary function tests. But usually you come into the hospital in the evening hours and you leave really early in the morning. So it is an overnight stay at a sleep center. And if you have a patient who's already on BiPAP, sometimes we can use a sleep study to help titrate that BiPAP to better settings. This is a brief kind of overview of what a sleep study is and how it happens. But I do think it's really important when your team talks about a sleep study. They're not just getting it for a reason. There's a good reason out there. If we can get a sleep study and pick up hypoventilation early, sometimes we can help treat the hypoventilation early as well, and people have a better night's sleep, and then they're healthier overall. I also feel like if we can pick it up early, we may be able to help some of the heart disease that happens with Duchenne muscular dystrophy. And we've certainly seen some patients who have cardiomyopathy kind of more stabilized when we've been able to improve their pulmonary function, or I should say improve their respiratory health. So it doesn't put as much stress on that heart that already has some stress because it's a muscle. So, and that just leads to some breathing support. So there's two kinds of breathing support that we talk about: non-invasive ventilation, which is BiPAP. It helps you take a breath in and it helps you keep those lungs open. That's why it has two settings on it. Overall, it basically is there to help a patient with breathing problems at night breathe easier at night. And like I said before, with muscular dystrophy, those muscles are weak. So it's really just a device that's helping those muscles move and open and close the lungs all night and breathe easier and keep that bad gas kind of in the normal levels and prevent any drop in their oxygen saturations, which can put more stress on that heart. The other type of ventilation that people talk about, this can happen with surgery, this can happen if you're in an intensive care unit, but it's called invasive ventilation. And invasive could mean that there's a tube in your airway, like in the operating room, but it can also be with a tracheostomy tube. And a tracheostomy tube, we really reserve for people who are using BiPAP for more than 16 hours a day, or if they feel like they would have a better quality of life, because a tracheostomy tube is a simple tube that goes into the airway, and you can connect the BiPAP or a ventilator to that if people need that. There's some fancy things out there, like when people are using BiPAP a lot or they need more support during the day, there's something called a SIP vent that it's kind of like a straw that anytime somebody needs a little bit extra support, that BiPAP can be connected to the wheelchair and they can just take a sip and it gives them a breath. Some of our Duchenne boys, or I should say adults who have jobs who have to do a lot of talking to their jobs, like this, because it helps them be able to take that breath anytime they want during the daytime. And it takes a little time to set that up, but it's something that's out there. So your pulmonologist will certainly talk about the need for BiPAP, and if it comes up and it's something that the family and patient want, you can have that conversation about a tracheostomy tube as well. There are a whole bunch of different machines out there to deliver ventilation. In neuromuscular disease, I would think that the Trilogy is probably the most used home ventilator device out there, but it's not necessarily needed. Other devices do the same thing. People just like the Trilogy because of its size and portability, and a lot of home care companies will like that because that's what they have. But I think that working with your team and working with insurance, there may be other devices out there that are equally as good or smaller, and will do the same thing that a ventilator will do. So the last thing I want to talk about before we run out of my 30 minutes of time, which I think I'm getting pretty close to, because I want to make sure that the people on here have plenty of time to ask any questions. And if you think of a question afterwards, by all means, feel free to send it to the Jett Foundation and they'll get that to me. But I think it's really important to remember that having an emergency care plan is extremely important. Most of the emergencies in Duchenne muscular dystrophy are going to be respiratory. Cardiac is probably right there as well, or some orthopedic complication, a broken bone, things like that. And obviously prevention of complications is the best approach. So, I think it's really important to have all of your doctor's numbers available, especially if you're in an emergency room where you may not be you may not know any of those people there, or perhaps you're on vacation and you're in a place that you don't know too much about. But I think it's always important and correct to make sure that the ER nurses and doctors and caregivers there know what the diagnosis is. Making sure that they know that, this is a patient with muscular dystrophy, and there are certain things that we need to make sure that we're monitoring in an emergency. I think that being prepared is obviously the best way of going about this. So breathing emergencies, happen a lot. Like I said, it's probably one of the more common reasons that somebody with muscle disease might be in the emergency room or the hospital. So, and the few things to think about, I know that there's a lot of things out there about oxygen and it can be very confusing. So I'm really trying to make this as least confusing as possible. So oxygen should not be used without checking for the carbon dioxide levels if we can. If somebody has an elevated carbon dioxide level and you put oxygen on them, then sometimes that will tell the brain that they don't have to breathe as much and the carbon dioxide level will go up. I know that doesn't seem intuitive, but that's the way our bodies are built. What I like to remind people of is, rather than just using oxygen, if they need oxygen, you need to use it. And I have a slide hitting that home too. But if the CO2 is elevated, then it may be more effective to start, like if you use BiPAP at home and it's 3 o'clock in the afternoon, it might say to the doctor, hey, can we put him on his BiPAP? I know it's not nighttime, but that might actually work better than the oxygen to improve their respiratory health. Or doing an assisted cough in the emergency room or at home if you're having trouble. Clearing those secretions may clear that mucus plug out and the oxygen will go right up. So oxygen, we all breathe oxygen. We all breathe 21% oxygen. That's what's in our atmosphere. Our bodies cannot live without it. And if there's something going on in the lungs, it's really important to keep that oxygen saturation normal. So I added this in, and I just want to read it, that oxygen is something that may be needed when patients are sick. Do not prevent anyone from using it. But the take-home message here is that if the child or adult with neuromuscular disease needs to be placed on oxygen, they must be monitored, and the team should consider using the cough assist or BiPAP or other forms of non-invasive ventilation to lower the amount of oxygen needed. So if someone is on their BiPAP and you've done the cough assist and they still have lower sats, absolutely use the oxygen. I think that's the most important part to that. And that's where it gets confusing. So the other time that we talk about being prepared is with anesthesia. So anytime someone goes to the operating room for a procedure, if that's scoliosis surgery or broken bone, dental procedures, anytime they're going to use some type of medicine that will sedate a patient and affect their breathing. It's important to take some time to think about what we can do preoperatively before the surgery, during the surgery, and after the surgery. So before surgery, I always feel like the proactive approach is best. I always like to talk about what we can plan to do. How do we get their lung function the best we can before going to surgery? You know, are there any other treatments we need to do? Are there any other tests that we need to do? You know, do we need to do another set of pulmonary function tests, or do we need an echocardiogram to assess the heart function as well? And I think it's always important and appropriate to meet and talk to the anesthesiologist prior to their care. And that's something you can certainly ask for. You know, I know you will meet the anesthesiologist on the day of surgery, but I don't think there's anything wrong with asking to talk to one of the anesthesiologists before surgery as well, or have one of us talk to the anesthesiologist if there are any concerns. Before I go on to that bottom line part, like during surgery here, like our anesthesiologists know that there are certain drugs that you don't use in Duchenne muscular dystrophy. We also are very good about doing cough assists and suctioning appropriately when patients are asleep. And our neuromuscular protocol here is, as soon as the patient is done with surgery and waking up, they are to be extubated to BiPAP in the right there in the post anesthesia unit, or if the anesthesiologist feels that they need help from the intensive care unit, we will transport that patient from the operating room to the intensive care unit, where our ICU doctors will extubate, take that tube out and put them right on BiPAP and monitor their symptoms. And we have this very proactive approach at our hospital. And whether or not people feel like we're doing too much, I'd rather take the conservative approach and prevent a post-operative complication than, you know, not do it. So that's my feeling about, you know, just being prepared, just like being prepared for an emergency. With surgery, sometimes we have some time to think about it. So I think that it is an important thing to just think about and to discuss with your team. So just from a bottom line standpoint, like when you're in clinic, please tell us about any breathing problems you're having at each visit. And even if they're happening in between visits, because we don't see you as much as maybe your primary care doctor, let us know what's happening in between visits. We do recommend that you get pulmonary function testing at least yearly, and some places may do it more than that. It's very important to watch weight and nutrition. We start drugs like prednisone that cause people to gain a lot of weight, and that can affect how you breathe. So nutrition is really key to that. Make sure that you have that support at home if you need a cough assist or we need BiPAP to help keep people out of the hospital system. Discuss these issues, you know, keep this open line of communication always with your doctors in clinic. And never forget to talk about sleeping in clinic. You know, people should be bringing it up, but if they don't bring it up, then you should bring it up. And again, have that emergency plan in place, you know, so that if emergency happens, you have all the things that you need. I always tell people another thing that's important, like if you have a cough assist at home or you have a special mask that they are comfortable with BiPAP, it's never wrong to stick it in the car on your way to the emergency room, or to, you know, bring it with you if they're in the squad, so that, because some hospitals may not have a cough assist readily available or the right mask to fit on the face to provide that support. So with that, I think that is my last slide. So I can stop sharing here and we can take some questions.
Yeah, thank you so much. I know that I learned a lot, so I really appreciate it, and I'm sure everybody here did too. Again, if you have any questions, please put them in the Q&A box, but I do have a few already. So first one is, I'm gonna kind of shorten it, but their son's 24 and refuses to use the cough assist, and also his Trilogy. No one's able to convince him to use it. Pulls his mask off at night and doesn't get very good sleep. He also has an inner turbinate hypertrophy, and surgery has been put on hold considering he has severe sleep apnea, obstructive sleep apnea. Besides post-spinal reconstruction surgery for scoliosis, he's also developed auditory hallucinations. So he's in the resistance stage of using his Trilogy. Oxygen sats dip below 90 when he's not on the Trilogy, but claims he gets better sleep without it. Any suggestions, and also what are the implications of possibly not using the Trilogy?
So, I feel for that story, and I would like to say that that's not, I would say it's more common than I think people talk about. Your son is 24, so he's an adult. And I usually take the stance that, when you're 24 and you're an adult, you can make decisions for yourself of what you want and what you don't want to do. And I would highly suggest that if at your center, if you haven't met a team, we have a palliative care team. We call it, they call themselves the AIM team, but they are a team that their ultimate goal is to talk about care that the patient wants, whether or not that's end of life care or palliative care, or something to improve their quality of life in general. And I think it's really important to have those types of doctors involved in a neuromuscular clinic, and I'm happy that we do, and that I can talk to them at any time. The other thing that might be helpful too, we have a psychologist in our clinic, and many children and adults with Duchenne also do have some behavioral issues, whether or not that is like attention deficit disorders or anxiety or other forms. We're learning more and more as we go along how dystrophin affects the brain, and I think it's a really interesting focus of a lot of people's research. But if there's anxiety about using the mask device or the BiPAP or any kind of therapy in general, there may be a psychologist that has good training in anxiety or could work with a patient to try to assess what's going on inside their head, like what is there a different reason, and we're just not addressing that. I know here at Nationwide we have sleep psychologists as well that work with mask comfort and getting adjusted to wearing BiPAP and things like that at home. So that's the first part of the answer to that question. The second part, is that if a patient who needs BiPAP or support at night doesn't use their support, they're taking a risk of harming their heart more because it's making their heart work harder. So they already have a cardiomyopathy, and we want to try to be proactive and protect their heart. But, there's also a risk of, not clearing those secretions, and those secretions getting infected and causing pneumonia and having complications from that. So, many of the things that we try to do are proactive and preventative. I don't like starting these things in an acute situation, but I have had some patients who end up in the hospital with a bad pneumonia, and we get them to use their BiPAP, and they see how much better they are after that. And sometimes they go home and use it, and sometimes they don't. So, there's no right or wrong answer here. When I look at this kind of care, I like to take the patient and family into account. And it's a choice to make as a team. I say that for a tracheostomy tube as well. Nobody should be forced into having a tracheostomy tube if they don't want one, but hopefully when people are talking to other families and patients about a tracheostomy tube, they're telling you what the pros and the cons of that would be. I know there was one comment too about, like, one of the cons of a tracheostomy tube is that they were told that their patient can't talk, and that's not necessarily true. Many patients are able to talk, maybe not as loudly as before, but we have ways to help people talk. And I even saw a patient with a tracheostomy tube the other day that eats everything orally without any complications, but that wasn't necessarily a patient with Duchenne. So I hope that helps answer the question. It's sometimes we're stuck between a rock and a hard place, and it may take some of these other specialists that specialize in the psychology of sleep or specialize in psychology, who may be able to help understand what's going through somebody's head that is preventing them from really wanting to use this.
Perfect. Thank you. We also have, will COVID continue to be a threat to our DMD guys?
So that's a great question. You know, it's been interesting to me that COVID hasn't, I mean, COVID is a threat to everybody. We don't seem to really understand all the people that get sick with COVID, why they get sick, why some people, you know, have a runny nose, and why some people end up in an intensive care unit on oxygen. It seems like obesity, being overweight, is one significant risk factor, along with being older, as well as having diabetes, is also a big risk factor. I think that, at least in my experience, we've had, I think, 2 patients so far with Duchenne that got sicker and ended up in the hospital with COVID, but they were able to recover from that. But for the most part, COVID should be treated as any other bad cold with a child with neuromuscular disease. If you have a cophosis, you should be doing it. You know, obviously there's risk there because that's an aerosolizing procedure, and it may cause, you know, people to also get COVID because you're right there in the secretions. But, you know, it's hard to say. We also now, for our older patients, have Paxlovid that can help, and we have the monoclonal antibody treatments that are still available out there. You know, there are going to be newer and newer variants, and I'm a big advocate for vaccination, and I'm ready for my 5th vaccination when they tell me that there's a new vaccine out there that will cover a lot more of these the variants that are out there right now. So I hope that answers the question.
Perfect. So I have one related to the COVID, so I'll ask that one first. Does Prevnar 13 vaccine last for a lifetime?
So no, the Prevnar vaccine is what we usually get when we are 2 years of age. We recommend the pneumococcal vaccine, and there's a pneumococcal vaccine that is both a 23 valent and I think there's a newer one out there that's 20. It is a vaccine that I always have to double check this, but the Academy of Pediatrics has changed this. It is definitely recommended in neuromuscular disease, and I believe you get one and a booster in 5 years, and then you're done. And I think it's also the same way if you're older than 65, maybe. Don't quote me on that one, but we do recommend Prevnar when you're 2, as any normal vaccination, and then the pneumococcal vaccine, that those booster series can be given. And most of the neuromuscular clinics that I've gone to review all have that available in clinic to give.
Perfect. Someone has a child with ADHD who is also nonverbal. When should you do the PFT study? Would you recommend that yearly still?
So I would recommend it yearly, but with the understanding that it may just be practice, and with the understanding, like, if there are things that your child responds to better, certain types of environments, certain types of ways to work with them, positive reinforcement, like prize or something like that. Some, like our center, has some games that you can play when you're blowing, like blowing out the dragons or blowing a house down, or like there's all kinds of devices to try to get people to understand what they need to do. But we usually start practicing around 5 years of age, and we know that we're not going to get really good details, but all I can say is, like, if the behavior is prohibitive and it just is a source of anxiety and something that just can't be done because of a child's behavior, then it's not something that we're ever going to force somebody to do. It's a data point that is helpful. But hey, if we can make it into a game and we can practice, maybe one of the times, you know, each time you see the team, you know, one of those times we may get some good data, or it's something that they will get used to and understand, like, this is part of my clinic visit, and then they'll do much better with it. But it's not something that we certainly have some patients whose behavior is prohibitive, you know, to doing this type of device, because you do have to be able to put your lips and teeth around a tube, and wear a little nose piece and blow your hardest. It is not an easy test for someone without neuromuscular disease. Like, when, you know, it takes your breath away because you're trying to blow every single last, you know, milliliter of breath out of there. So it is a learned test over time. So the more you expose somebody to it, the better they do sometimes.
Yeah, I've done it myself. It's not easy at all. And then last question for now that I have is, how often would you do a sleep study?
So once patients have symptoms, I believe that the research shows that if your PFTs get into the 60% range, we should start talking about that. The guidelines that are out there recommend that you should get a sleep study after that point every year, and it pretty much coincides with loss of ambulation. I don't know that I completely believe that you need to get one every year. I think a sleep doctor wrote that. And I've worked with a lot of sleep doctors that also say, like, if you have a baseline sleep study and you're good about asking the right questions and the parents are good about monitoring for symptoms, that, maybe if you have a normal study, you get another study if you see a dramatic change in their pulmonary function tests, or if there's a dramatic change in their symptoms, like, do they get tired during the daytime? Are they falling asleep watching TV? Or if they have a hobby or something that they're really interested in, are they having trouble concentrating on that kind of stuff? Do behaviors change? Like, is there a dramatic change in their overall behavior? That's a hard one because many of these kids are on steroids that dramatically change their behavior as well. But it's definitely a conversation to have, and sleep studies can be a pain in the butt. So I'm at least someone who's certainly open to monitoring closely and doing the sleep study where we think is the most appropriate.
Perfect. And then another question, can one use an incentive spirometer as part of breathing exercises?
Sure. Anything in my book that makes somebody take a big deep breath and get air down into the deep parts, nooks and crannies of those lungs, I think is important. An incentive spirometer, for those who might not know, is just a little plastic device that you inhale. And you try, like, it's really great for patients who are post-operative or patients who have pneumonia in the hospital to help clear the secretions. I would expect that someone with neuromuscular disease can't inhale as deeply. So, it's also good to, like, some patients really hate the cough assist. So I'll tell them to do the inhaled part and skip the exhale part and do something more fun, like give them a big breath with the cough assist and take it away and have them blow in a kazoo or blow into an instrument or blow a pinwheel, something that is more fun that helps them exhale as hard as they can. And sometimes by blowing out really hard, you'll get them to cough and clear secretions. So there's lots of ways to do that overall.
Perfect. All right, well, that was the last question. If anybody has any questions, like Dr. Shell said, you can send them to me, alexa@jettfoundation.org, and I will make sure that they get to him. I know that sometimes we need some time to process, the presentation and all of the information that was given and then come up with a question. So please feel free to reach out to me if you do have those questions. We do have one more. Are there any breathing exercises that you would suggest for children and adults?
There's some research out there about breathing exercises. I think, anything, taking as big a deep breath as you can, or, if it's a young child, using things that are fun to blow into, because that'll make you take a big deep breath. There are manual forms of cough assist where you have someone take a big deep breath and then you can push on their diaphragm to help them cough too. It's definitely something that you can talk with in your clinics with the physical therapist or with the respiratory therapist that might have some other ideas than I do that can talk about breathing exercises. I don't necessarily prescribe breathing exercises necessarily for our patients. We focus on them, and especially when they are losing some function. We haven't found anything that prevents the respiratory function from going down, like we talked before, besides steroids and some of these other drugs that slow the progression. But there hasn't really been a breathing exercise that has slowed it. My gut feeling is that people who who use a cough assist when they need to and do that type of therapy every day seem to sometimes stabilize, but not everybody does. We tried to do a study on that, but it's really hard to do a study when you're dependent on compliance of a device at home sometimes. So we weren't able to prove anything, but we're still kind of looking at that. And in the back of my head, I wonder if some patients do better just by doing some of that every day.
Perfect. All right. Well, thank you, Dr. Shell. We really appreciate all of your time and again, your knowledge and sharing this with the community. Again, this is recorded, so if anybody wants to rewatch it, they're welcome to do so. Share if you feel anybody needs to see this. So that will be it for us today. Again, thank you, and we hope to see you again soon. So
Absolutely. Anytime.
have a wonderful day, Dr. Shell. Thank you again.
Thank you.
Bye.
Bye-bye.